I would like to introduce our next speaker, Dr. Yoshna Kooverjee. Dr. Kooverjee is a medical doctor working as a senior lecturer at Nelson Mandela University School of Medicine. She completed her medical degree at the University of Witwatersrand in 1999 and returned to the Eastern Cape for internship and community service. During community service, Yoshna completed the diploma in mental health through the Colleges of Medicine of South Africa in 2001. She worked in both the public sector and in private practice. Yoshna completed the postgraduate diploma in general practice, followed by an MPhil in applied ethics, so bioethics at Stellenbosch in 2018, and her clinical interest include addiction medicine, and she completed the PGDip in addiction care through Stellenbosch University in 2021. Yoshna currently lectures first and second year medical students in theory and practice of medicine, and she also enjoys sharing her knowledge of ethics with health professionals at CPD events, where she strives to bring bioethics to life. Thank you for joining us.
Thank you very much. Good morning, everybody. And so today a very interesting and important topic, informed consent in transgender children and youth. Okay, so the outline for the talk today is we're going to look at the informed consent model of gender-affirming healthcare, ethical aspects of informed consent in TGD minors, legal aspects of informed consent, and then gender-affirming guidelines for informed consent. So the informed consent model of gender-affirming healthcare was first introduced by the World Professional Association of Transgender Health Standards of Care, version 7 in 2012. And I know that we are currently on version 8, 2022. But this is where, it was first spoken about as an alternate to the standard model of care. And what's important about this informed consent model of care is that it's much more patient-centered. And so the priority is really on patient agency and looking at and enforcing the patient's right to personal autonomy. So just a very brief background to this, this model really looks at how to enable people to choose care options without gatekeeping. Recognizing that it's the patient's lived experience that makes the patient the best judge at looking at balancing risks and benefits, balancing the principles of non-maleficence and beneficence against the person's right to autonomy. So it is very much a collaborative approach with a therapeutic relationship based on trust. And the idea is to counter the medicalization of gender identity, which we've heard quite a lot of discussion about, and I almost kind of had to pause when I thought about, do we say gender dysphoria, so specifically in terms of today's topic in minors, so for adolescents, this approach allows for a tailored approach to stage 1 and stage 2 treatment. Okay, so and I think it's very important before we actually move on to the actual topic of informed consent, just to also discuss some of the controversies in the informed consent model. So these are not new conversations, but there was just recently, very recently, a paper published by these authors who are well known to be part of the anti-trans lobby groups. And I think it is very, very important for us to kind of look at these questions and see, so that we can also meaningfully answer them. So some of the questions that are being raised still are, at what age is meaningful consent possible? A note that there is a lack of standard criteria to assess competence for informed consent. Is gender incongruence or gender dysphoria lasting? And if it is not, then what about regret and detransitioning and the iatrogenic harm that may come about from offering interventions to transgender and gender dysphoric children and adolescents? And one of the arguments that they put forth with regards to this is that the task of identity development is a central task in adolescence. And is this attempt to offer an informed consent model of gender-affirming healthcare, not a disruption of the natural course of resolution? So I'm not going to debate these controversies. That is not the point of the discussion today. What I really would like to do is to talk about some of the ethical and legal aspects of informed consent, and then look specifically at the recommendations that are in place for informed consent for gender-affirming healthcare in children and adolescents. And hopefully in the course of those discussions, most of these controversies will be answered. Right, ethical aspects of informed consent. So I think most people are familiar with this theory of principalism, which was developed by the philosophers Beecham and Childress in 1979, and is arguably, the most widely used ethical theory in bioethics. And so essentially, principalism looks at 4 principles: respect for autonomy, non-maleficence, justice, and beneficence. And you will see that they're not a hierarchy, and therefore we have this interacting circle. These principles must be weighed and balanced against each other. And so although we talk a lot about respect for autonomy in the informed consent model of gender-affirming healthcare, it's important to recognize that respect for autonomy is not a principle that just overrides every other principle, and is very much about weighing and balancing risks and benefits. So the principle of respect for autonomy, according to Beecham and Childress, this principle requires that we acknowledge patients' rights to hold views, to make choices, and to take actions based on their values and beliefs. So allowing a patient to make the final decision regarding treatment after providing all the necessary and relevant information. There are some obligations for clinicians that arise out of this principle: informed consent, confidentiality, truth-telling, and effective communication. And certainly all of these come very much to the fore when it comes to gender-affirming healthcare. Right, so let's look at informed consent in a little more detail. So informed consent is both an ethical and a legal requirement. Many clinicians do think of it as a legal process that you need to get that signature on the page, but it is a process which occurs over time and is not a quick once-off conversation. Some of the terminology around informed consent is informed decision-making, because it's not necessarily consent. Sometimes it is, declining the intervention, and dissent doesn't sound like a nice word. So we talk about informed refusal. And lately, the terminology is also moving even further from informed consent to shared decision-making. So some of the general principles of informed consent. You can either get express or explicit consent, which is done verbally or in writing, or you can get tacit or implicit consent. And this is implied. So while it's not spoken, it is implied by behavior, for example, nodding or extending an arm for a blood test. Obviously, in cases of surgery and big life-changing interventions, such as in gender-affirming healthcare, consent must be in writing. Both are legally binding, so even verbal consent is legally binding, but of course one needs to show evidence, and written consent provides better evidence. And just to note that especially in the case of surgery, informed consent must be obtained by the treating doctor, and it's not a task that can be delegated to somebody else solely on your behalf, such as a nurse or a student. Okay, so according to Beecham and Childress, there are 7 elements of informed consent. So firstly, there are preconditions, and once you've met the preconditions, then there are the information elements, and once the information elements have been satisfied, then there are the consent elements. The preconditions are competence and voluntariness. And competence is the one we're going to discuss a little bit more, naturally, because we are talking about children and adolescents. The information elements include disclosure of all the necessary information, recommendation of what intervention is recommended by the expert, whether it's the mental health practitioner or the surgeon or the doctor, and ensuring that the patient has an understanding of all the risks and benefits. And that must be followed by the consent elements. So the person must be able to express a decision, make a decision, and authorize that decision. So looking at those preconditions in a little bit more detail, we said that the preconditions are competence and voluntariness. And I think it's appropriate at this stage to talk a little bit about legal aspects. So I know there is a little bit of an artificial division in the talk, with headings of ethical aspects and legal aspects, but here you're going to find me referring to the law as it arises. Okay, so competence is actually a legal term. It's a legal judgment that looks at 2 factors, the age and the decisional capacity of the person. And then capacity is much more of a clinical judgment, and this is looking at the functional ability to make a specific decision. So it's a judgment of the ability to provide or decline consent. And it's important to remember that this capacity varies. So it can be context dependent, whether it's a simple versus a complex decision, and that fluctuations will occur over time. Naturally, in our group of interest here, we're talking about as adolescents develop, we would expect that capacity would develop as well. Right, so looking at legal capacity, firstly, age. So in South Africa, 18 years is the age at which a person is considered to have full legal capacity, and together with that goes a presumed decisional capacity. So under the age of 18, capacity is outlined in the Children's Act number 38 of 2005. So children 12 years or older with maturity, sufficient maturity to understand the decision or the matter at hand, and mental capacity to do so, can consent to medical treatment. However, when there is surgical treatment involved, then this child of 12 years and older with maturity and mental capacity must get a parent or guardian's written assent for the surgical intervention. A child under the age of 12 years or a child who's 12 years or older and lacking maturity, you then do need the parent or the guardian's consent for both medical and surgical treatment. Interestingly enough, when it comes to a medical intervention, then a caregiver, so in other words, a temporary caregiver, such as whoever is looking after the child for the day, can give consent for medical treatment. And again, that would be, we would probably be looking at something sort of short term. So the second component of legal capacity is decisional capacity. And adults are presumed competent to make decisions. So you need to be sure that capacity is lacking if you're going to do an intervention without informed consent. Okay, and this is actually a very useful, these two principles are very useful principles, and you can see I've referenced Sandy Anthony there. This comes from the MPS guidelines, and these 2 points are actually quite useful then. So if in adults you're presuming that they're competent, you've got to make sure that if you're overriding informed consent, you've got to make sure that they don't have capacity. And in minors, it's the other way around. In minors, you can presume that they don't have capacity. So you need to make sure that if an intervention requires informed consent, that they are able to give that informed consent. Very useful principle. Okay, so let's look a little bit more at the standards of capacity. So although the heading says competence, we're actually talking about decisional capacity here. And Applebaum and others, these are sort of the recognized authors who've done a lot of work on this. So although it is an old reference, these are, the standards that are referred to. So Applebaum identifies the abilities that we need to say that a person has capacity, that they are competent. Firstly, they must be able to express a preference. Secondly, they must understand the situation and the consequences. Thirdly, they must be able to understand relevant information. And fourthly, they must be able to give a reason for their choice. The fifth level is that the reason must be a rational reason. The sixth is that they can take risk-benefit related reasoning. And lastly, that they can reach a reasonable decision. And by reasonable decision means that somebody else, would reach the similar decision. So Beecham and Childress, our philosophers that we're referring to, our ethicists that we referred to earlier, they speak about levels of competence, and just reminding us that if you're incompetent for certain decisions doesn't mean that you're incompetent for all decisions. And this is useful to bear in mind when you're talking about children and youth. When it comes to minor issues, example, what choice of clothing, and if a transgender child wants to wear, a certain clothing, and they just need level 1 of capacity to be able to express a preference. But when it comes to a more serious issue, for example, social transitioning, and if you move higher up, moving then onto puberty suppression, then there needs to be at least a level 5 where they must be able to make rational arguments. And this, particularly in terms of children now, we obviously have to look at the law as well. It's not just about the ethics. So Beecham and Childress, they do recognize that we do have the sliding scale strategy. And the sliding scale strategy says that, if the intervention is more risky, then the person needs to have more competence, more intellectual ability. But what they're arguing is that it's not so much the ability to make the decisions, but rather that we should put more effort into to determining the level of competence of the person to make that decision. Again, that is actually quite an important concept if you think about children and sufficient maturity. Okay, and then I just want to talk about Gillick competence. Gillick competence is something that doesn't apply in South Africa really, but if you're reading the literature, this does come up. And essentially in UK law, but it's also applied in Australia, New Zealand, Canada, and I think a couple of other places. And it refers to a 1983 case. So in the UK, there's a right of under 16s to access contraception without parental consent. And Victoria Gillick, was the mother of a child who then went to court because she, wanted to challenge this ruling. And so this case was important because the judgment from this case then set out criteria, because obviously there was a realization that there aren't actually criteria for competence, no standard criteria, as I've said in the beginning. So this case then set out, and it's called the Gillick test, and they set out some of the criteria to determine whether a child under the age of 16 has capacity for consent to treatment. And so it's really looking at functional decision-making ability, and it is task-specific. So again, as I've mentioned in the previous few slides, you need greater levels of competence to be able to take more serious decisions. Right, does not apply in South Africa, but if you do come across it in the literature, this is what it means. Right, some operational tests of competence then. This is clinical assessments of capacity, and here you would call in your mental health provider teams. I think most physicians and GPs would be comfortable doing a mini mental status exam, which is scored on 0 to 30, with under 19 indicating a score that the person is less likely to be competent to make a decision relating to this serious intervention that we're talking about. There are other tools. The MacArthur Competence Assessment Tool for treatment is a 20-minute structured interview tool, and you could easily refer your patient to the mental health practitioner in your team. And then again, just to point out, there is no standard test for minors. Okay, so we've spoken about competence as a precondition. The other precondition for informed consent is voluntariness. So an action is voluntary if a person desires it without being controlled by another person or condition. So there are three categories of influence that we need to be aware of. Firstly is coercion, then persuasion, and lastly manipulation. So coercion is the intentional use of threat or harm to force or control another person. And again, this is something that you're going to really be worried about in a young population. Persuasion is using influence but not control, so appealing to reason versus appealing to emotion, trying to persuade a child perhaps that they really don't want to transition. That is something to watch out for. And then manipulation, so straightforward lying, withholding of information, or misleading by exaggeration. There are conditions that diminish voluntariness, such as debilitating illness, psychiatric disorders, and substance use. So just to talk a little bit more about factors impacting voluntariness in gender-affirming healthcare. I think the audience is very well aware that there's an unequal power relationship between the patient and the medical practitioner, and this can definitely fall in the side of persuasion and coercion. We are well aware of paternalism in medical practice, and sometimes also just unintentional, where if the practitioner, and I think that is said to be often the case, where the transgender or gender dysphoric person would know much more about the issues than the practitioner treating them. And then, of course, a very important thing is historical experiences of the patient and gender minority stress. And I mean, I'm pretty sure this audience would know what gender minority stress is, but essentially this model looks at the unique and hostile stresses related to sexual identity and posits that they actually negatively impact health. Things like prejudice, discrimination, that patients have to conceal sexual orientation or internalize societal stigma, and this leads to gender minority stress, which ultimately impacts their health negatively. And this definitely can impact voluntariness, fear of being open with your practitioners, and especially in children, where children take on social context very easily and they know about cues and what is expected of them from a very young age in terms of conforming to gender norms, and a fear of shame, when they don't conform. All right, so then moving on to the information elements, which are disclosure, recommendation, and understanding. So disclosure plays a pivotal role in the consent process. And I think most practitioners in this room, I really not the audience I should be talking to, but essentially we're obliged to disclose core information. And And this perhaps is just, again, touching on the point of just the wider education that needs to happen. Core information around facts that patients would consider material, facts that the professionals would consider material when it comes to gender-affirming healthcare, the professional's recommendation, the purpose of seeking consent, and the nature and the limits of consent. Again, also very important to just touch upon this difference between the professional practice standard, which can be quite problematic, versus the reasonable person standard, which is the legally accepted standard. So a professional practice standard would say, well, a doctor would say that, other doctors would expect a person to know this or to disclose that information. But actually legally, it would be, what would a reasonable patient expect to be told around a condition, risks, benefits, and so forth? So for the understanding part of the information elements that follows on from disclosure, Beecham and Childers point out that, at the minimum, you need an understanding of what an attentive healthcare practitioner, right? So not necessarily the ideal or the specialist, but an attentive healthcare practitioner would believe that a reasonable person would want to understand in order to be able to authorize this intervention. So usually things like diagnosis, prognosis, the nature of the intervention, and the purpose of the intervention. Of course, the alternatives, a lot of time spent on risks and benefits, followed by recommendations. Okay, and then moving then on to the consent elements. So we've looked at the preconditions, we've looked at the information elements, and now we're looking at the consent elements of informed care. And essentially there's two parts to this. It's not enough just to get a signature on a page, okay? So you must document the patient's decision. That's part one, the decision, what the patient decided on the treatment plan, and then the authorization, the signature on the page. Decision aids can be useful in general, which provide important information and allow patients to reflect on their values and preferences. And I think it is well documented in the literature that patients often, there's information overload in the session or in the consultation, and going home, the patient does need to be able to have some kind of aid, even if it's just a patient information leaflet and not even a decision aid, just something to recap and to reflect upon what they actually want. And then just a caution that is related to this is that when there is a strong evidence for a procedure, then a decision aid should support uptake of that. So it's not just a matter of choice. It's a fine line between persuading, because you're not appealing to emotion, but you do need to be able to give evidence so that a reasonable person would reach the same decision. And one has to be wary of the risk of paternalism. Okay. Right, so let me just pause there. That is a lot of information, I know, very, very, lots of information in a short space of time. And yeah, so I think if anybody does have any questions about these things, I would encourage you to perhaps maybe start typing them in the chat. And then let's move on to the legal aspects of informed consent. Right, so as I mentioned before, I've already spoken a little bit about laws that impact gender-affirming healthcare in children and adolescents in South Africa. So really what I want to look at here about legal aspects is more about what information must a doctor provide to patients by law, when can a patient be treated without consent, and what happens if a patient's right to informed consent is violated. So, firstly, law and the duty to inform. According to Section 6 of the National Health Act, number 61 of 2003, healthcare practitioners must inform users of their health status unless it's against their best interests. You also need to tell the patient about the range of treatment options generally available, the benefits, risks, and consequences of each option, and very importantly, the patient's right to refuse and the implications, risks, and obligations thereof. I think this becomes also quite important in gender-affirming care when we're talking about reversible and irreversible changes, and I'll touch upon that just now. Also very important, especially in South Africa, we need to inform the user in a language they understand and at an appropriate level. So obviously with children at a child-appropriate language. Okay, what does the National Health Act say about treating somebody without their consent? So again, this is just general, not specifically related to gender-affirming care. If a patient is unable to consent, then you can get consent from a person who is mandated by the patient in writing. If the patient doesn't have such an advance directive, then or if there's no mandate, then it's in the following order: the spouse or the partner, the parent, a grandparent, an adult child, a brother or a sister, okay, so a sibling. And following that, if you can't get any of those, then you can get consent authorized by law. For example, in the Mental Health Care Act, then you don't actually need consent from any of the people I've mentioned above, or you can get a court order. If there's a serious public health risk, then you must treat the patient and you don't need their consent. And if a delay will result in death or irreversible damage and the patient has not refused, then again, you can treat without consent. Okay, so let's look then at treating patients, minor patients without consent, just some pertinent facts related to gender-affirming care. So according to the Children's Act, a parental refusal to consent to orthodox treatments. And I think this is going to be quite the interesting, discussion point then. If a child is at risk and the patient is refusing to consent to standard treatments, then you need to refer to your institution's legal department to get consent from the court or the Minister of Health. This is, of course, if it's not an emergency situation. Also important is that the Children's Act says that every child has the right not to be subjected to social, cultural, or religious practices that are detrimental to his or her well-being. Okay, lots to talk about there in a conversation, I think, for another day, and what exactly constitutes well-being. Right, and then also our Constitution, Section 28, outlines that the child's best interests are of paramount importance in every matter concerning the child. And so definitely when a parent is not consenting to treatment for minors, then the Constitution does then have a say. Another interesting thing that I came across, and I just thought quite briefly about this, and perhaps some of the clinicians in the room can explain this a little bit further, but I did want to include it, and that is that I think the Sterilization Act also comes into play here. And so even though you're not, so firstly, let's talk about what it says, right? So you may only sterilize a child if their life is going to be jeopardized or their health seriously impaired without performing the procedure. And you need the parents or the guardian's consent, as well as an independent medical practitioner who are going to consult with the child and provide a written statement that is in the best interest of the child. So I know that gender-affirming healthcare, it's not directly sterilization, but I'm just thinking in terms of what happens, and it's just ringing some bells for me in terms of the rule of double effect. So, it may not be an intended consequence, but I think it is an intended consequence, even if you don't like the terminology sterilization, looking at unintended but foreseeable negative consequences. Some interesting things to think about there. Okay, so what happens if we violate informed consent? So informed consent, if it's not obtained before the procedure, the patient can lay a criminal charge against the doctor. It would be a charge of assault. And that's obviously not a route that we want anyone to take against us. Or a civil case, which is usually what happens. Interestingly enough, in terms of the law, it's invasion of privacy. But they can also lay a complaint with the HBCSA and or against the employer if you're working in the state, and then you would face disciplinary action. Right. Okay. So again, a little bit of a pause. I'm just going to invite you to think about that, and we'll look at the comments afterwards and have some discussion. So the third part of the talk, I want to then look at the gender-affirming guidelines for informed consent, and this comes from the HIV Clinicians Society guidelines, and really looking at what the guidelines then say about informed consent in minors. So when it comes to informed consent for psychosocial care in children under the age of 12 years, the mental health practitioner must obtain consent from the parents or guardians for collaborative participation. So obviously all these evaluation support and counseling can only occur when you've got the parents and the child involved. And it's important because, they do acknowledge that family support leads to better outcomes in gender-affirming healthcare. Part of that conversation, something that's important is to address the limitations of confidentiality. And then it's also essential to explain the findings to the parents and the child, not just the parents. And of course, for the child, it's in an age-appropriate way, and then recommend an intervention, for example, social transition. So you can see now that these are all the steps that I've just outlined when it comes to the ethical aspects of informed consent. You do need to discuss risks and benefits and the support if the child changes their mind at any stage. And remember, this then was talking to what the anti-trans lobby is saying. And I think it's important, and the guidelines do state that it's important that the child does need to know that they are allowed to change their mind, and that support will be there. It also states that we can begin social transition after you've got assent from the child and informed consent from parents or guardians. Remember, the child is not allowed to give consent at this age, but can give assent, in other words, agreement. So what they do note is that the prepubescent children usually present with parental requests. So it's the parents coming to you asking for support, and that does make it easier. But you do also have situations where parents or guardians disagree, or one parent disagrees, or they are not acting in the child's best interest, and then you would have to then go the court order route. But the guidelines caution that you should try to avoid this, again linking to that family support leading to better outcomes. When it comes to informed consent for psychosocial care in children 12 years and older, it becomes more complex, because although children 12 years and older are now allowed to give consent, for themselves, when they are, this stage is usually not just psychosocial care. There would also then be a plan for additional medical intervention, such as puberty suppression or hormone therapy for gender affirming care. So if the child has already had previous engagements, they've already done the social transition, then it does make the work a little bit easier, because probably the health profession has already been engaged with the parents in the counseling and so forth. And so now it's taking the next step in collaborative engagement regarding puberty suppression and eventually the path of gender affirming hormone treatment. So here it's important to discuss the risks and benefits, especially which changes are reversible and which changes are irreversible, and also by when the changes become irreversible. Something that's also very interesting to point out, which you may not necessarily think about, is also to explain the endogenous hormones. If there's no hormone therapy, at what stage do the endogenous hormones have effects that are irreversible on the transgender or gender dysphoric child? And then again, just, making it absolutely clear to the child or the adolescent that it is acceptable if this adolescent experiences changes in gender identity. They must be able to feel free and safe to know that there is the possibility of diversion from transition once they are on the path. Another important point that the guidelines point out is that there are comorbid mental health conditions. We did speak about minority stress earlier. And it's important for the child or the adolescent to be aware that, firstly, that those comorbid mental health conditions are not necessarily part of the transgender and gender dysphoric identity. They can also happen, anxiety, depression, etc. And they're also not an exclusion criteria for gender affirming healthcare. They also note that gender incongruence or dysphoria may sometimes first be experienced at puberty onset. So this is not the previous group that we spoke about, where the child has already socially transitioned and been evaluated and supported. And if this is the case, that it's the first experience at puberty onset, then you do need to balance this adolescence. There's often the sense of urgency, according to the guidelines, where the adolescent wants to transition quickly, socially and medically, as puberty is distressing then, versus parental anxiety and this overwhelm because it's a new thing, but there's this sense of urgency. And so the guidelines caution that you must ensure that there is due diligence in informed consent in this situation. And lastly, they identify a case of if there's referral from other sources, so schools, whatever the other sources are, or if the parents are unsupportive, then again, if it's against the best interest of the child, you can go the court order route, but that brings with it, obviously, it's a situation that you want to try and engage the parents as much as possible before going that sort of last resort route. Okay, when it comes to the next stage, which is puberty suppression or hormone therapy in adolescents, then the recommendation from the guidelines is that we need a collaborative, supportive context, and using the multidisciplinary team with expertise. And we've heard from previous speakers that actually is a challenge. There may not be a team with expertise. And this is where things like the guidelines and the efforts that are being made to include gender affirming healthcare education are going to pay off down the line. So we need to get the support of the parents or the legal guardians as far as possible, and the adolescent must understand all the risks and benefits, the reproductive health implications, and the options available to them. Too much to talk about in this talk, but again, just linking, to that Sterilization Act, and for the child, or the adolescent rather, to know that there are options for the future, egg harvesting, and so forth. Okay, so the guidelines also note that pubertal suppression should be offered to adolescents experiencing persistent gender incongruence and who wish to alter development of unwanted secondary sex characteristics that occur in puberty from teenage stage 2 onwards. So, the adolescent maybe experiences urgency, but you should be aware that you also then should, according to evidence-based medicine, offer the care. And they do note about the special population, that is the transgender or gender dysphoric adolescent with autism spectrum disorder, that it can be difficult for an ASD adolescent to comprehend long-term risks and implications of interventions. And so informed consent does become much more complex in this situation. And lastly, the gender affirming guidelines outline then the informed consent for surgery in adolescents. And again, as you can imagine, a very big topic. And so they make reference to the Center for Gender Surgery in the Boston Children's Hospital, which requires 2-parent consent. Okay, so we've spoken about what the Children's Act in South Africa requires, but I think here again, good to have that extra level. 2-parent consent is except if it unduly interferes with informed consent of the minor and the possibility of significant harm. They note that it may be difficult or unfeasible because, many transgender youth have complicated family situations. And especially in South Africa, just youth in general may not live with their parents, and guardians would be reluctant to make a big decision like this, due to the nature of their care, that the child is in their care for a short time. So the recommendations are that you need the involvement of both parents and the health team, plus the multidisciplinary team comprising of the mental health care practitioner, the surgeon, the transgender adolescent, and the parents, which I've said already. And also involving both parents acts as a check, they say, on the possibility of impulsivity. So again, addressing that concern that what if the child is going to change their mind? I think by now you can see that with this informed consent model, it is quite a staged process. And by the time this young person reaches this stage of surgery, we do hope that the possibility of impulsivity and that it decreases the likelihood that later on there's going to be decision regret related to decisions made in adolescence. Okay, so yeah, that's quite a lot of information to pack into a very short talk. I didn't really get a chance to look, and I don't even know if there is literature. Perhaps somebody in the audience can tell me about cases and case law related to things like surgery in adolescence. But I think that leaves us some time for questions and discussions.
Thank you so much for the talk. I found it very informative for myself. I've just looked at the chat, and Ron, you were asking a question. Do you feel it was answered on the chat, or would you like to ask it now?
Sorry, thanks, Alon. And I think it was answered. I think for me, obviously those of us that work in the psychosocial field and are working with young people, in many of the thank you so much for your presentation, Yoshni. There's the emphasis on the age 12 and in regards to medical treatment and surgery, and then there was always the question from the psychosocial practitioners: is that equally relevant to the social worker or the psychologist who's also seeing the young child? Is it also, can the 13-year-old request and go and see a social worker or a psychologist and give consent for that a process, maybe feeling that they're not ready to come out to their parents or for their parents to know. So we've always understood that it does include, but I guess I'm always looking for people who have the knowledge and the expertise, as our speaker does, to kind of definitively say, yes, the law is also applicable, to the psychosocial practitioners as it is when it comes to the medical and the surgical.
Yeah, I think that is it is a valid point, and you can imagine that in that situation how difficult it is, because that child under 12 is going through and is requesting help from somebody. But they're not really allowed to give consent themselves. And I think this is where then that whole best interest and the constitutional aspect of acting in the child's best interest comes into play.
Excellent. Thanks for that, Yoshna. And so, I mean, so I guess what you're confirming is, so often in the high school scenario, where your 13 or 14 or 15-year-old adolescent, requests to go and see the school counselor, and wishes for that to be confidential, and their gender identity may then be part of the content. We now understand that, yes, the young person can do that and can give consent, for that, to engage in that process, and it need not necessarily be disclosed to the parents. And then the dividing line being age 12, and if they're younger, then maybe, Yoshna, I think the point that Ariana then makes, which is then the challenge in the school environment and with the younger kids, because, around puberty and puberty pausing, as she mentions, puberty starts age 8 or 9. So there may be obviously a cohort of young transgender and gender diverse young people who are in situations where their family context, for various reasons, religious, cultural, personal life view, etc., the context in which the young person is may make it very challenging for them to get their parents on board, to support them in moving forward with their gender affirming healthcare. And I guess, as a social worker in particular, I'm not aware of any cases yet, but I'm assuming that age range arena of, say, your 8 to say 11, 12-year-old, are we going to see cases in the future where parents who are not willing to be supportive, and it now moves into the terrain of these parents aren't acting in the best interest of their child? And we may then have, professionals like my colleagues as social workers possibly needing to step in and consider, do we have a case here of, parental neglect, in that the parents are being the obstacle to the young person accessing the gender affirming care that they need? And are for example, the social workers going to need to be the next level advocates? And are we going to see cases where we go to court and a judge is going to need to make a decision that this 9, 10-year-old that is wishing to have, puberty pausing, for example, but their parents are refusing, and that it could be found that these parents aren't actually acting in the best interest of their child?
Yeah, it's very, very interesting, scenarios that you raise, and I think that they are entirely possible. Obviously, it's a developing in a new sort of arena in South Africa, and I think that's also why I put in that slide about Gillick competence, because for me it's so interesting that they in the UK then, and obviously the countries that are following the English law, 16, which in South Africa is practically an adult. I mean, when you look at, and especially you look at that age of 12, and I was looking at those MPS guidelines, I referenced Sandy Anthony there, a very interesting booklet to look at, because they list so clearly the different things, and you can hear me paging now because I really just want to quote it. So they've got a table that talks about the current legal situation regarding clinical treatment and the age at which a child can consent, but then they've got little bits of comments next to it. And for me, it still stands out there very interesting that, so for termination of pregnancy, for example, there is no lower age limit at which a child can consent. So in other words, if a child is considered old enough to have conceived, whether it's intentional or as a consequence of rape or whatever, right, that child, the law says no consent other than that of the pregnant woman, I guess it should now say child, shall be required for the termination of pregnancy. And so it says here, for the purposes of this act, woman means any female person of any age. And so there you go. Those are the interesting exceptions, so there probably will be situations where, and so certain situations, and if you can say that the puberty suppression is going to be urgent, there are going to be irreversible needs, and obviously those criteria for competence and so forth come into play. It's not inconceivable that there are going to be conversations, as you say, where social workers have to advocate. It's going to be difficult. I don't think it's going to be as straightforward as just advocating for that.
Thanks so much, Yoshna.
I see there's a hand raised.
Yes, that's me. Can I go ahead with my question?
Yes, please do.
Thanks. Thank you so much for your presentation. It's fascinating to think about all the ins and outs of consent. One of my anxieties, I suppose, is that the very complexities you present could play into the hands of the proponents of the anti-gender movement, who would argue that consent in a younger person is so complex that, in fact, we should avoid it entirely and wait until the person is much older for consenting to for example, puberty blockers, or of course, puberty blockers might be too late by then. Is there a way that the complexity can be re-strategized around from an activist point of view? For example, the fact that there are so many steps undertaken means that when consent is finally achieved, it is clearly a very good thing at that point, with so many steps have been undertaken.
Yeah, I think what your question is actually speaking to is this whole informed consent model of gender affirming care. And I think, and that is why this whole model arose in the first place as an alternative to standard care, because there is this realization that there are so many steps and you do need to provide all this evidence, but also just unpacking all the uncertainties at every step of the way for everybody involved. That does, I think, provide a strong argument against the points raised by the anti-trans movement. I think we all wish it would be something as straightforward as a checkbox approach, where we say, okay, we've done this, and there's your proof. But unfortunately, in ethics, it never is a one size fits all. But yeah, and I think and I say, I'm probably speaking to the wrong audience here, because everybody here is practicing this informed consent model of gender affirming care. But yeah.
Thank you.
Thanks so much. Sorry, Pierre, that I missed your hand there. I was stuck in the chat box with my lack of tech savvy. Does anyone else have any further questions? I've now figured out the raising hands part, so you can do that. Okay. I see Chris. Chris, you've got a question?
I do indeed. Regarding working with young people that may be on the spectrums of neurodiversity, we know currently there's a lot of research done in this field. And the interplay between neurodiversity, the ability to give consent, and then the age, where does the responsibility then in the end lie? So let's say we have given all the information that the child and the parent needs. They are above the age of 12. Let's even make them 15, 16. But due to neurodiversity, there is a question mark then. How much does it then become that the clinician needs to say, look, this is what is needed, or how much rights does the kid have? Because we are seeing a lot of turmoil around this field currently, and a lot of very unhappy young people that is now starting to shout the words gatekeeping into our community. And I just wondered, I know it might be a very unfair question to raise towards you, but maybe just your thoughts, and then maybe what other people's thoughts are regarding this, please.
Thank you, Chris, and thank you for acknowledging. I mean, this whole field is actually very, very new to me. There's this field of gender diversity, and it's been very interesting to delve into it, because you really start thinking about informed consent in a new way. And yes, I would welcome any additions to the comments that I'm going to make now. So essentially, just to answer your question, so that is why they do say that legal capacity is made up of age and competence. So age alone is not a criteria. Exactly as you pointed out, that you've got patients on the neurodiversity spectrum, and yes, they may be 16 or 12 or whatever, but age as a criteria alone does not stand. So when it comes to legal capacity, and in South Africa particularly supported by the Children's Act, if you remember that the Children's Act there, it says age of 12 plus sufficient maturity plus competence. And I think that is very, very carefully thought out. And so I think that, and then I'm sure that was designed also as a counter to this thing where it's just age alone, because again, as I say, Gillick competence 16 is very different from 14 where I'm sitting, you know. I don't know if anybody else wants to respond to that. And Casey, I see a hand raised and you may want to respond.
Thanks, Yoshna. Yeah, this is something, sorry, just bringing the computer closer and knocking things over. This is something a few of my colleagues and I have been talking about extensively, because with the new information around neurodiversity coming out, a lot of our mental health professionals and colleagues are still working from the old paradigm of very stereotypical like identifiers for autism and neurodiversity, whereas the newer lens from the neurodiversity affirming perspective is finding many more people who are on the divergent spectrum, and in many different ways that people have not been previously recognized, but have many traits that overlap when it comes to the neurodiversity and trans stuff. So I think the biggest thing that I've come across is our colleagues in the medical and mental health profession are often framing trans stuff as a medical thing, even if they're not intending to. And I think we have to be very careful for how we phrase and talk about things in terms of language. So something that came up, I thought I put it in the chat, but I can't find it now. Instead of using comorbid conditions, talking about co-occurring, because being trans is not a condition that is pathological or can be treated. It's not something wrong, therefore there's no fix. And for some people with very rigid thoughts processes, if the people that they consult about their gender thinking and questioning confirm that gender is a medical thing with a medical fix, we fall into some scary gray stuff. And I'm not like, medical stuff is a huge part of gender affirmation, but it's not a fix for a problem, because being trans is not a problem. And I think we have to be careful in how we are talking about these things when speaking to our clients, the public, etc.
Thanks, Casey. I think, you know, that's exactly what we've been seeing also or for me in any case, in all the previous oral presentations today, you know, that there are changes that need to be made. It is not about pathologizing and medicalizing. It is about advocacy in the education space as well, but not just reaching the new people, but also people like us, you know, and you just start using words like comorbid as a routine, or gender dysphoria, you know, when we probably should be talking about incongruence and you know, just hearing, you know, Jude's phrase about gender euphoria. You know, those are the things that need to become part of the mainstream.
Thank you so